Hi, my name is Elliana Kirsh DeVore, and I am a first-year resident at the Harvard program in Otolaryngology. I would like to thank my co-authors and especially my mentors, Dr. Shin and Dr. Carroll. Today, I will be exploring whether the Reflux Symptom Index predicts proximal reflux events on hypoesophageal multi-channel intraluminal impedance and pH testing. Given its spectrum of presenting signs and symptoms, laryngopharyngeal reflux, or LPR, is difficult to define. As many of you know, LPR classically refers to stomach contents reaching the larynx or the pharynx. The diagnosis may be supported on the basis of patient symptoms, laryngeal findings, and objective reflex testing. However, laryngeal findings vary in their sensitivity and specificity for diagnosing LPR. In addition, the ability of validated symptom questionnaires, like the Reflux Symptom Index, in aiding the diagnosis of LPR remains controversial. Historically, pH-only testing has been the mainstay for diagnosing LPR. Dual-channel pH 24-hour monitoring with esophageal and pharyngeal probes have been shown to be effective in detecting LPR. This test involves placement of a single catheter through the nose and into the esophagus, with a distal pH sensor positioned approximately 5 centimeters proximal to the upper border of the lower esophageal sphincter, and a proximal sensor placed some increment above that. A positive event is considered a pH drop in the proximal probe. Pharyngeal-only pH probes have also been demonstrated to detect pH changes in the pharynx, but do not reliably detect non-acid or weakly acid reflux events. These events are important as non-acid refluxate has caustic properties that likely plays a role in LPR symptoms. Multi-channel intraluminal impedance catheters afford detection of liquid reflux events regardless of pH. The impedance electrode pairs detect presence of a liquid by measuring change in resistance to current flow when interfaced with electrolyte-rich fluid. That is, impedance between the electrodes decreases in the presence of conductive fluid. When multiple electrode pairs are mounted on a single catheter, directionality of the bolus movement can be measured. Thus, we can determine retrograde flow. A specialized impedance and pH catheter is available to better diagnose LPR. These catheters include pharyngeal impedance electrodes to detect liquid escape into the hypopharynx, as well as pH probes and impedance electrodes buried in the upper esophageal sphincter, or the UES, and the proximal esophagus. Thus, it is termed hypopharyngeal-esophageal multi-channel intraluminal impedance testing with dual pH monitoring, or abbreviated HEMII-pH catheters or LPR catheters. Thus, the goal of the study was to determine the ability of the RSI to predict HEMII-pH findings of proximal reflux events, or those events near but not crossing the UES. We also wanted to compare this to our previously determined ability of the RSI to predict pharyngeal reflux events. Subjects were consecutive adults presenting to a tertiary care academic center with a primary voice complaint. All patients were asked to complete the Reflux Symptom Index, a 9-item outcomes instrument designed to evaluate symptoms of LPR. An RSI score of greater than 13 is considered abnormal, but this was not a requirement for inclusion. Patients also underwent objective voice testing via combined neurolaryngeal task and stroboscopic examination on a distal chip flexible laryngoscope. Patients were sent for reflux testing based on clinical acumen, not just RSI score or laryngeal findings. Objective testing for LPR was performed using HEMII-pH monitoring in coordination with high-resolution esophageal manometry. As mentioned, the distal pH center was positioned above the LES, and more specifically, a proximal pH sensor and impedance electrodes were buried in the cricopharyngeal muscle. Pairs of impedance electrodes were also located in the proximal esophagus and the hypopharynx. A positive test was defined as more than 6 proximal episodes over 24 hours, or more than 1 pharyngeal event over 24 hours. These are normative values based on clinical trial data from HEMII-pH catheter testing. The primary outcomes were sensitivity and specificity of the RSI to predict positive HEMII-pH results. The secondary outcome was to compare the RSI's ability to predict proximal versus pharyngeal episodes. During the study period, 734 new patients presented with laryngeal complaints, and among these, 306 had suspected LPR. These patients all completed the RSI and objective voice laryngoscopy, but did not necessarily undergo HEMII-pH testing. Upon correlating laryngoscopic findings with clinical symptoms, concomitant laryngeal pathology, and patient follow-through, 100 patients ultimately underwent HEMII-pH testing, and these constitute our study population. These are the demographic characteristics for our population. The average patient age was 56 with a female predominance, and 73% had concomitant voice diagnoses, of which the most common are listed. The average RSI score was 16.7, and of note, although this is above the normal cutoff of 13, only 32% of respondents had a response greater than or equal to 13. Thus, according to the RSI, only 32% of patients were eligible for a diagnosis of LPR. However, when we look at HEMII-pH findings, 41 patients had more than 6 proximal events, or events that did not cross the UES. Thus, almost half the patients experienced enough proximal events to be considered abnormal and possibly contribute to LPR symptoms. Meanwhile, 75% of patients, or 75 patients, had one or more pharyngeal event over the course of the 24-hour testing. This is considered above the normative value for LPR events. Thus, pharyngeal impedance testing revealed double the amount of LPR patients than did the RSI. We found that the RSI was not able to specifically predict patients with proximal reflux events near the UES. Specifically, the RSI had a sensitivity and specificity of 63.4% and 28.8%, respectively. In terms of detecting pharyngeal events, the RSI had a sensitivity and specificity of 69 and 26.2%. As you can see, the confidence intervals here overlap. However, the McNemar chi-square test showed that differences between these values were statistically significant with a p-value of 0.0016. This study examined the ability of the RSI to detect proximal reflux events on HEMII-pH testing and compared its ability to predict pharyngeal reflux events. The data demonstrate that the RSI is moderately sensitive for suspecting LPR, as later confirmed by HEMII-pH testing. However, the RSI is not specific. In addition, the RSI prediction of pharyngeal versus proximal events may be statistically different. Interestingly, the RSI had a higher point estimate sensitivity for pharyngeal events compared to proximal events. Inclusion of the hypopharyngeal electrode, and not just those in the mid or proximal esophagus, or those that just detect acid, may explain the study's observed relationship. As has been demonstrated, inclusion of a pharyngeal probe is essential for capturing true LPR patients. In our study, not all patients with one or more pharyngeal events had 6 or more proximal esophageal events. Although proximal events are more reliably reported, they may not fully capture LPR events, thus the pharyngeal probe is truly essential. It must be emphasized that only 32.7% of patients scored greater than or equal to 13 on the RSI, while 75% experienced more than one pharyngeal impedance event on HEMII-pH testing. This suggests that the RSI alone cannot guide suspicion of LPR. We have seen this in practice. Patients with isolated chronic cough, for example, may demonstrate pharyngeal reflux events despite not achieving an RSI score considered pathologic. Thus, LPR requires a multifaceted approach to diagnosis, including patient-reported outcomes with objective and clinical data. The study has limitations. Although the RSI is the most commonly used reflux-specific health measure in the United States, it represents just one LPR-specific health status measure, and assessment with other disease-specific instruments relative to the HEMII-pH testing may be warranted. In addition, manometry data was collected but not evaluated in the current study, and may be intimately involved in evaluation of LPR patients. The study was conducted at an academic subspecialty clinic, and thus results may not be generalizable outside of this environment. And finally, while HEMII-pH is considered the gold standard by many to diagnose LPR, there remains incomplete acceptance and, more importantly, availability of this technology, as well as agreement on how to interpret findings diagnostic of LPR. However, in conclusion, there is moderate sensitivity and lack of specificity of the RSI for detecting proximal esophageal and true pharyngeal LPR events. In addition, there may be differences in patient-reported symptoms associated with proximal versus pharyngeal events. Further research can assess the ability of the health status instruments to detect clinically meaningful change as confirmed by HEMII-pH testing.